Everybody can hear me? كويس. بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا ونبينا محمد وعلى آله وصحبه أجمعين. I would like to welcome you to our first course in trauma in children. As you know, this is a 12 hours CME, and you have to attend at least 70% of the time, so you can have this 12 hours credit. The course will be today and tomorrow, and we will try to finish as early as possible. And those who are participating in this course, I have the pleasure to present them. Dr. Hamad Al-Madi, who is a consultant in pediatric emergency medicine at Prince Sultan Military Medical City, and Dr. Salih Al-Shihri, who is also a consultant pediatric emergency medicine at Prince Sultan Military Medical City. Our course title is First Trauma Care Essential for Children First Responder Course. This will deal mostly with traumas, how to approach trauma in children. Okay. And can you see the screen? Okay, great. So our first lecture will be approach to multiple trauma in children. As you know, trauma in children, it is a common presentation to the emergency department. And before I start, I have to declare that I have nothing to declare. And as I mentioned, pediatric trauma, it's common in children, especially the younger age group. And as we know that most of the trauma in children depends on their age sometimes. You know, the younger the age, they have more trauma because secondary to fall or secondary to sometimes motor vehicle crashes. And the older children, they may prone to sport injuries also. And the most important in approaching multiple trauma in children is evaluation. You know, and evaluation children, like we have the rapid assessment for airway, breathing, circulation. It's like, you know, the ATLS, who attended the ATLS course, I'm sure they know these important items for evaluation: airway, breathing, circulation, disability, and exposure. And we have to intervene immediately if there is any risk of airway compromise, and immediate stabilization and management of life-threatening injury. Okay. Also, we have to consider the diagnostic images, okay, like utilizing the X-rays, ultrasound, CT, and we will go and talk about it, and continuous monitoring for these children. As you know that the common causes of trauma in children, as we said, like significant trauma, it's mainly secondary to high-speed collisions, and especially with those children in the car with the unrestrained. Falls also, this is one of the things that's sometimes, especially at the younger age group, and in older age group, as I mentioned before, sport injury. And as I mentioned, in assessment and management of multiple injuries, we should consider rapid evaluation and stabilization, and consider what kind of testing or imaging that we should do. Okay, so, and also it's only pediatric assessment, and also we have to assess and help the family, because sometimes the family member, they are involved also in the management of these children, and at the end with the psychological support, what we call it. Okay, to make it easy, okay, I will start with this case, and we will follow, okay, and see what we can do. Okay, and please, if there is any question or anything during the presentation, you can write it down in the question area, question and answer. We'll start with this case, and my goal actually to make it easy and simple. I know some of you, they are from other places, from other hospital, maybe in the periphery, maybe in the area where they don't have like full support, okay, because some kind of traumas that you should have like you know, specialized surgeon in pediatric and orthopedic anesthesia, all this, you know, and that's why sometimes in some hospital we don't consider them like a trauma center. And for example, like in Riyadh, we have a few centers that we consider them like a trauma center, okay, like King Abdulaziz National Guard Hospital, or King Abdulaziz Medical City, which is the National Guard, and Shumaisi King Saud Medical City. Okay, they are considered like a trauma center, but they are not like level A trauma center. We didn't reach this level yet, like in North America with a North American standard. But still, we consider them like a trauma center. And that's why when we have like a significant casualties, or we usually send them to these places, okay? And so, but here, when I present this case, I just would like that to show you how to manage these cases. And I made here two cases, and they are very significant injury. They have very significant injury, and just to make you sure that we can manage any case coming to the emergency if you follow the guidelines. Okay, sometimes you will do your best and the patient, unfortunately, he died. Okay, and sometimes you may do a great job and he may survive if you follow the guidelines. And usually in trauma, we follow the ATLS guidelines, which is airway, breathing, circulation, okay, etc. So let's start with this case. This is a 12-year-old boy who was involved in a high-speed motor vehicle crash. On arrival to the emergency, he was unconscious with a bag valve mask ventilation provided by EMS paramedics. His initial vital signs were, you know, as I mentioned, he's 12 years, so his heart rate 150 per minute, his blood pressure 70/40, his respiratory rate 30 per minute, and he has a shallow breathing. Okay, and he was on, as we mentioned, bag valve mask ventilation. His temperature was normal. Okay, so his saturation, auto saturation, was 85, even with 100% oxygen by bag valve mask ventilation. So what do you think wrong with this patient? Is he in shock? We need all of you to participate in the chat area, please. Yes, he's in shock, absolutely. And and also his oxygen saturation is only 85%. However, we are providing him with bag valve, so 100%. So he is significantly hypoxic, okay? And blood pressure, as you mentioned, yes, he's having hypotension. 12 years old. What is the normal accepted, not normal, what is the minimal accepted blood pressure for this patient? Can you tell me? Okay, 94, above 78. Okay, 70 plus 2 by age. Excellent, Hitaf. You're right. And also somebody's mentioned 94, somebody mentioned 78. No, 78. No. Below 90, he's hypotensive. يعني the minimal accepted systolic blood pressure is above 90. Below 90, for this age, we consider him hypotensive. يعني as Hitaf mentioned, 70 plus 2 by age, he is 12. So by 2 is 24. So 70, this is 94. So as Bandar al-Qahtani mentioned, okay, and Hitaf mentioned. So he is hypotensive. Okay, so we have to be careful with this patient. Okay, we may lose this patient. By the way, I present this case, and this case can be seen anywhere. And for example, in المزاحمية, in القريات, in العلا, anywhere. Like, where they have like an emergency department. They don't have, for example, let's say pediatric emergency staff. They don't have, they have general practitioner. And I can assure you, if you just please listen and concentrate with me, we can manage this patient. And this is the case that we usually face if he has a significant injury. This is the worst scenario that we may expect. Okay, so what should we do for this patient? Okay, anybody can tell me? Okay. Oh, increase the volume. Okay. All right. Yes, as mentioned, ABC. Absolutely right. Okay. So what we should do approaching this patient, okay, we should follow ATLS guideline, A, B, C, D, E. This is the most important, okay? And as long this patient, he was already have a significant injury, so you have to be careful with the airway and C-spine protection, okay? Because most of the time they are at risk to have C-spine injury. Also, breathing with adequate ventilation, okay? Circulation is very important. Disability, neurologic assessments, and exposure. Because sometimes, okay, we are seeing patients like this and concentrating more on head injury, okay, and ignoring the rest of the body. And this is very fatal mistake, because sometimes we are having patient coming and we are managing the patient, giving fluid, giving everything, and still the patient, he didn't recover and he is still hypotensive. And later on, we discover that he has significant femur fracture and there is like a deformity in his lower limbs and he's losing a lot of blood there. So that's why exposure is very important, but you have to be careful with the temperature, body temperature, because children, they are more prone to hypothermia. And if they have hypothermia, this even will aggravate the outcome and it will be a poor outcome. But this is very important. So what we should do next, okay, on examination, as we mentioned, this patient, just to let you know, okay, the airway was already applied oxygen, ambo bag, okay, and we protect the C-spine, we put a collar, and we notice that there is a decrease air entry on the right side, okay, decrease air entry on the right side, okay, and he is already hypotensive, so what we should do, we have to, as Shajil mentioned, Jawa, maintain 2 wide pore IV lines, and we have to give a boluses of fluid. Excellent. Okay. and to maintain the blood pressure to improve, as well as we have to take a set of labs to do cross-match and all the trauma labs, okay? And also to assess for disability, okay? Like what is the Glasgow Coma scale? And we said, as we mentioned before, exposure is very important. Okay, so here Bender, he mentioned that we should do needle decompression. Okay, so let me see. We'll go next. So we open the airway by jaw thrust and apply semi-rigid cervical collar. Okay, and we relieve the right, okay, tension pneumothorax, okay, and by inserting a large pore 14 to 16 IV catheter at the mid-clavicular line, second intercostal space, and it should be followed immediately by chest tube. Is that clear? Any questions so far? Mm-hmm. Okay. And this patient also, go ahead, Alia. This patient, once you release the right tension pneumothorax, they may also need immediate intubation because he is hypoxic, significantly hypoxic. Okay. Yes. Okay. He is already 12 years old, so he is. We consider him like, okay, like an adult. And even this is for children because, you know, the smaller the chest, also you will go with the fifth intercostal space. This is the right place. Okay. Bye. So let's go to the scenario. This patient presented to the emergency, brought by the paramedics. He's hypotensive, he's hypoxic. There is a decreased air entry on the right side. And what on percussion, let's say hyperresonance. So most likely he has a right tension pneumothorax. So you have to immediately insert. Let me tell you one interesting thing. And usually this is in North America and Canada and in the state. Usually when they have these cases coming to the emergency department and they are hypotensive, hypoxic, they put 2 tubes in both sides of the chest, okay? Expecting, especially if there is a bruises in the chest, okay? When they expose the chest and they notice there is a bruises in the right and the left side, they will put blindly a chest tube on both sides. Okay, because they are expecting this is the cause of because in a very busy emergency it is very difficult to examine and assess. Very noisy, you are, oh, there is hyperresonance, there is I cannot hear, decreased air entry, I cannot do this. This is expected. Okay, so what we did for this patient so far, as I mentioned, we provide ambo bag initially. We provide fluid, and it should be done simultaneously. Yani not necessary to manage the airway and to hold managing the circulation. Patient hypotensive, he needs fluid. So you come and say, no, airway first, and then after we finish. No, you should go simultaneously, all together. But the idea behind the ATLS is to make you well organized and not to miss anything. So I think till now, we are doing a great job. Even if the patient died, you did the right approach, okay? But you should do it as soon as possible. You shouldn't be late, okay? The other thing, okay, for example, this patient we insert, okay, there was somebody here talking about doing an urgent X-ray. Sometimes it's really difficult and it is time consuming unless you are in a very good center where the X-ray it's next door. يعني بالغرفة اللي جنبك. Okay, let's do it. But sometimes even it will delay the management. So I go ahead, even if there is no pneumothorax. But the patient is very hypotensive, okay, and giving fluid, and there is no improvement whatsoever. So what you should do? Put it a chest tube. Okay, let's go next. So we establish, after you put a chest tube, okay, you have to intubate this patient because he's hypoxic, significantly hypoxic. So you have to have a definitive airway. What do we mean by definitive airway? Definitive airway, by definition, means tube in the trachea, okay? So by intubating the trachea, and you can ask for help if you are not experienced. And this is what we are usually doing. When we have a significant trauma in the emergency, we announce code, either code green or code blue, whatever. Okay, your hospital is activating, or what kind of code they will activate. So you should ask for help if you are not experienced in airway management. Sometimes, in multiple trauma victim, even he has significant facial injury, okay, and it's really difficult. So that's why you should ask for help. Then we ensure a good oxygenation for this patient, and ventilation. So insert a large pore right-sided chest tube. This is what we mentioned early, without any delay, and then give 1 to 2 liters of normal saline or ringer lactate and reassess. I hope now, till this stage, I think this is very simple. We can do it, okay, as an emergency physician, okay? And this is a very significant trauma. Until now, even we didn't, the surgeon did not arrive, the anesthesia did not arrive, nobody arrived or anything, okay? Okay, so what we should do next? So then also we have to go ahead and see, okay, what happened with this patient. We keep doing, also following the ATLS. And I encourage you all, to be honest with you, those who are attending or working in the emergency department, they should do ATLS course, either a nurses or a physician, because there is ATLS for nurses and there is ATLS for physician, which can give you, it will make you more organized. Okay, so and then for disability, we have to assess for Glasgow Coma score. Okay, and as you know, this is out of 15. Usually, 3 is dead, we consider it. Okay, this is the minimal score, the highest score out of 15. Okay, so, and then E, expose the patient and check for site of active bleeding, skin, and musculoskeletal system to make sure. Maybe, as I mentioned, maybe he has a deformity in his thigh, maybe he has bruises in his abdomen and slightly distended. So you have to expose and to make sure. Secondary survey, which is full examination from head to toe. Okay. Adjuncts, when we put insert what we've been mentioned before, for needle inserting a cannula, we can draw blood for trauma screen, and also for cross match, which is very important. Okay, and then whenever you do anything, you have to keep reassessing your patient. This is very important, especially this patient. Okay, trauma. Once you intubate the patient, then you reassess how is the patient is doing, how is his oxygenation, once you give fluid, how is the blood pressure, how is his heart rate, how is his everything. You don't have to do all these things and then you ignore your patient, because sometimes they may deteriorate, especially if they have like a significant injury. Okay, so we reassess this patient, okay, like in 30 minutes after what we did for this patient so far. Now we have to see what we did so far. Okay, so in 30 minutes, this patient, let me see here, somebody was saying site of needle decompression and chest tube at different age. As we know, small size of chest tube need decompression can be damage how much depth can we go? Okay, Alia, this is I don't blame you for this question, okay, but if you are in the emergency and you did one time only a chest tube, you will find how easy and how very simple, even in children. Okay, you have to go, as we mentioned, in younger age group you have to be careful not to damage the liver. Okay, for example, if you are going on the right side, okay, that's why, you know, the smaller the age, the chest will be small, and even fifth intercostal still will be way above the liver. So I don't think it would damage unless you will put it in the abdomen. But this is very unlikely, but this is wrong. Okay, and usually now, to be honest with you, we are putting a chest tube under ultrasound guidance in like big centers. Okay, but I'm giving this lecture for those, for example, those who has no advanced trauma like facility. Okay, and you directed your tube upward, you shouldn't direct it downward. Okay, usually unlikely to have damaging the liver. I hope I did answer your question. So in 30 minutes, so needle thoracocentesis, we noticed there is a gush of air, okay, and 200 cc of blood, then stopped. Also, there is like some blood coming out, hemothorax, and the patient was intubated, okay, very good, and ventilated, and 2 liters of normal saline were given. So this is what we should, you know, somebody is recording for all the procedure that we are doing. And after initial stabilization of the vital signs, luckily the vital signs were improved, okay. But we noticed like after 30 minutes, the vital signs start deteriorating. Like the pulse rate, it went down to, let's say, 90, now it is 110. Blood pressure improved after the first bolus of 2 liters and then went down to 80. And his saturation 90%, okay, on 80% of oxygen. So what does that mean? This is like the patient is now, he improved in the first few minutes and then he drifted down. His heart rate started increasing. His blood pressure initially went up to 100 and then now it is 80 drop. So what do you think the cause? Can somebody tell me? Excellent, Abrar. Yes. Patient could be still losing blood. Okay. So what do you think? ABC. Excellent. So we should go back and reassess our patient, because this patient could still have, okay, bleeding, ongoing bleeding. Okay, so how can we reassess this patient? Yes, patient in shock, because he is, we believe, this is the most common cause of shock and trauma patient, bleeding. Okay. Okay. So we should go ahead. What we should do and why he is deteriorating. Excellent, Fahad. Fahad al-Mutayri, Abrar, you are right. So fast, which is bedside ultrasound. Okay. But before we go to the ultrasound, okay, when the patient is stabilized initially, we should do some adjuncts x-rays, okay? Like for this patient, lateral C-spine x-ray. And somebody will ask how we can read it, doctor. This is important. What kind of x-ray we should do? We usually do C-spine x-ray, chest and pelvis. This is the standard, okay, for any trauma victim coming to the emergency. Of course, we shouldn't do it while we are resuscitating the patient. But once we stabilize the patient, we should do this, of course, after applying the C-collar and everything. And how to read it? Very simple. You can see the X-ray. Can you see my mouse here? Well, I cannot see it. As you see, the first X-ray on the left side, this is the most common X-ray that we use it for C-spine. And sometimes even we don't have to do the anterior posterior X-ray or the open mouth X-ray. By the way, there is a mistake here. I think Amal Guri, okay? She said, I would go for CT. Who agree with her? With Amal? How many yes, how many no? With this patient? Yes, Alia. CT for what? No, no, no. كلهم no. Yes, 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 yes. Excellent, excellent. I like those who said no. And those who said yes, this is a fatal mistake. Unstable patient, no. Thank you, Khawla. Okay, so you have to be careful. Okay. Anna Paula, Dua, and Khawla, and Bandar. Yes, you are all right, Bayan, and okay, Zainab. Roseanne, yes, yes, yes. We shouldn't do a CT for unstable patient. I remember one patient came to our emergency. She is a child who is 5 years old, and she has a significant trauma. We intubated her, we give fluid, we give everything, and her blood pressure is still unstable. And the surgeon, he came and he said, excuse me, doctor, I need to take her to CT. I told him, she is not stable. He said, no, because I need to know. She has a significant head injury, she will go to neurosurgery. If she has abdominal injury, we will take care of her. Because this is not our patient till now. You see, because this is always what happened in the emergency department. I told him, well, you are the surgeon now, and she is your patient, but as an advice, okay, don't do CT because she is not stable. He said, okay, not because you are an instructor in ATLS, you will teach us what we should do. I told him, no, this is just an advice. They took the patient to CT, and there she arrested, okay? And they start doing CPR. And they shift her immediately to OR, and in the way they keep doing CPR for 30 minutes, and unfortunately she died. And this case went to the court. Okay, so you have to be careful. Patient hemodynamically unstable, I shouldn't send him to CT. Please, this is very important message. Let's go to the X-ray. Here, the lateral C-spine, so we have to, anybody can read it, because significant head injury or significant trauma, simply you can see the abnormality. The most important here, for example, you have to make sure it is a proper lateral C-spine X-ray. So the base of the skull there, and you should count 1, 2, 3, 4, 5, 6, 7. So seven there. So this is enough. Then you can draw a line, anterior vertebral line, posterior vertebral line, and then the spinous line. It is all you can see go smoothly, slightly curved, okay. There is no stepping out or stepping in. There is no soft, significant swelling. There is no clear fraction. So this is most likely normal. And in children, usually the percentage or for cervical spine injury, it is really low. Okay. Then after this, we'll do the chest X-ray. As you can see here, this is pneumothorax, okay? And the chest X-ray. Even as I told you, if you don't have the facility there within like 1 minute to do it, just go ahead and put it, and you are suspecting. You don't have to be sure 100%. You are suspecting. For example, there is bruises in his chest, okay? Go ahead, okay? And put your chest tube, okay? Then, yes, what about pelvis? Because pelvis is still, it is very common, okay? This is Turkey. He's asking about what about the legality of inserting a chest tube in the emergency without X-ray. Well, let me tell you, in Canada, in USA, they are inserting, and there is a study supporting this. They are inserting the chest tube sometimes even without doing an X-ray. If you have a high suspicion, okay, you have to justify. For example, you say, well, there is a lot of bruises in the chest. I can see. And when I just palpate, I feel like there is a flail chest. I notice maybe he has a rib fracture and he is hypoxic. And I cannot. So you have to go with your clinical judgment. And in real life, it is easy. And I don't think you have any problem. Okay, so now how to read the pelvis. Also the pelvis, you can read it very. What is the common injury in the pelvic in a patient who involved in a trauma? Usually the weakest bone, we consider it even in the body. Here, it is the superior ramus and inferior ramus of the pelvis. And usually they have fracture. But the management is conservative, nothing to be done. And sometimes we have to widen it into the symphysis pubis. And you have to make it circle, just to go over the pelvis and make a circle. If there is no step in, step out, so you cannot miss out any superior ramus, you know, here. I hope my, what's that? Pointer is clear. Okay, inferior here, rami, right or left, and also the pelvic bone. If there is any fracture, it will be clear. Okay, طيب. Excellent guys. لا ما شاء الله يعني. طيب. Okay, so we'll go next. So this patient, as most of you said, we have to do fast. Okay, and this is what we did. So we give 2 boluses, another bolus of 2 liters, okay? And usually now in the new ATLS guidelines, they are advising, because most of the time, this is like blood loss is hypotension. So they are advising to give blood as early as possible. After the first bolus, you may give the second bolus, and then the third bolus should be blood. Or sometimes even the second bolus, you can give a blood, because you know he is losing blood, okay? And you can have to look for other sources of bleeding. So, okay, and you examine this patient, even if he is intubated. This patient, we touch his abdomen and we notice he has some, there is no distension, but he has some like tenderness. So we did fast and there was a significant bleeding there. So what we should for this, do for this patient? Okay. We call the surgeon, already arrived, okay? So should we send him to CT? No, this is major mistake. So this patient, he should go immediately to OR. Excellent, Ali, okay? And Hassan Ad-Din, you are absolutely right. So we should take this patient immediately to OR and to explore and see. Okay, repeat, there is a significant, yes, lacerated spleen, which required partial splenectomy. Okay, and then the patient will be taken to the ICU. Okay, do we have to do partial splenectomy for all patients coming to the emergency? And they are, you know, most of the abdominal trauma, and this will be another lecture, I think tomorrow, okay, most of them, they don't need exploration and they don't need partial splenectomy. It will heal, you know, spontaneously without any surgical intervention. But because this patient, he has significant hypotension and he is losing blood, and so most likely he has like a significant arterial bleed, so we have to do partial splenectomy for this patient. So this patient went to OR and they did for him partial, and he improved after a few days staying in the ICU. So see what we did for this patient. It is really simple. You don't have to be worried. You don't have to be, you know, thinking that, oh my goodness, there is something significant. No, no, no. all the things that you can do it in the emergency, but you should be confident. Okay? Right. So what is the most important message here? Patient who present with multiple trauma and shock, look for tension pneumothorax. This is very important. And relieve it immediately, even if there is no chest x-ray. Okay, this is very important. And don't intubate before, okay, the tension, release tension pneumothorax, because this may aggravate the problem. Okay, needle decompression of the pneumothorax should be followed immediately by chest tube, and also look for ongoing bleeding in a patient who do not respond well to fluid resuscitation. Like, where is the common area, okay, of bleeding in any trauma victims? Can you tell me? Okay, it's written there. Okay, usually in the chest as a hemothorax, abdomen, you are right, pelvis, and thighs. Some people, they ignore the thigh injury, usually because a long femur and there is a femoral artery, okay? It has a significant loss of blood up to 30%, okay? And this leads to significant blood loss and hypotension. Also, in hemodynamically unstable patient, fast, we can do ultrasound, okay? And now ultrasound is considered to be mandatory for every emergency physician, okay? Working in the emergency department to be certified and fast, okay? Because this will help to identify any bleeding very fast, okay? And can be used in a triage, as a triage tool in hemodynamically unstable patient, okay? Not responding to boluses and fluid. Okay, and patient to decide if the patient should go to for a laparotomy and to look for other causes of shock. طبعا DBL اللي هو deep peritoneal lavage, this is very old and it's not anymore used. Okay, and never take an unstable patient to CT. This is very important, guys. Okay, do you have any question for this patient? Okay, before we go to next patient, and now I need you to manage the next patient. Yes, here is a question, Alia. Okay, she is oriented to adult. Okay, it is almost the same. Okay, Alia, it is almost the same. And if you have any doubt, you can do ultrasound and okay. But I'm a pediatric emergency physician. I'm an ATLS instructor. Okay, and usually you deal with pediatric patient the same way you deal with adult. Okay, with a special, you know, there is some differences, but the approach is almost the same. Okay, right. So let's go to the next patient, and I need you to be the one who will manage this patient. This is an 8-year-old girl who was struck by a car, because we are running out of time. We have only 5 minutes to go. She lost consciousness and she was brought to you in the emergency department by bystander. Okay. And on arrival to the emergency department, bleeding from the mouth, shallow rapid breath, and respiratory pulse rate 150, blood pressure 70/45, respiratory 35, temperature 30, saturation is 80. So what do you think? Let's concentrate on this patient. A, B, C, D, excellent. Apply C color, excellent. Okay. Excellent. I think so we'll follow the guidelines as we mentioned before. Okay, and this is what we find out. She is bleeding from her mouth. There is a broken incisor. Okay, and she has, and this is very common, you know, shallow rapid breathing and reduced air entry over the left chest, and normal percussion and trachea at central, weak rapid pulses, deformed left thigh with an overlying deep wound, a motor abnormal flexion, verbal incomprehensive sound, no response to painful stimuli. This is the eye, and exposure we notice there is a deformity of the left thigh, and secondary survey distended tender abdomen. So what do you think? يلا يا جماعة quickly. Okay, so what you should do? Tell me. Okay, excellent. So we should consider airway, breathing, circulation, exposure, and all these things. So for airway, this patient should be intubated. خلاص, don't waste your time. حتى sometimes, I will tell you one thing, even if there is a hemothorax or pneumothorax or whatever, okay, and it will take time to insert the tube, intubate. Yalla, no problem. Okay, and this is what we are doing in real life. Okay, and then you may consider putting a chest tube or whatever. Yes, it is advisable that you shouldn't intubate unless you put a chest tube in tension pneumothorax or in hemorrhagic pneumothorax. Okay, but sometimes you don't have the facility, so I will go ahead and intubate the patient. Okay, bye. And so this patient was intubated, neck collar was applied, okay, and hardboard. طيب, would you intubate this patient while the collar on, or you should remove the collar? You are suspecting significant injury. Who will say yes, I will remove with collar on? Alia, I'm gonna kill you, Alia. How you can put a chest tube while the collar is on? You never. Nobody can intubate a patient while the collar is on. You should open the collar, especially the anterior part. Okay, remove it, because the collar, once it's on, his mouth is closed. So you have to remove the collar and intubate the patient, and then you can put the collar back. Okay, or for example, like this patient is already intubated, immobilized, and everything. خلاص, you can stabilize the neck by putting the sandbag on both sides and just put a tape. Okay, طيب, you got it, excellent. So, and then this patient, okay, intubated, we noticed that his oxygen is 60%, even yeah, he was given oxygen, then it improved to 92, excellent. Cannot find an IV. Yeah, this is a common problem, especially in children. There is no IV. What should we do? Of course, immediately put IO, intraosseous. In PALS, they mentioned that you have to try 3 times. This is old PALS, but now we should go ahead and immediately put intraosseous. Okay, and we have to give like 20 cc per kg. This is for children usually. Okay, so we give it. Okay, the blood pressure improved to 90/60. This is excellent. Okay, and the heart rate from 150 it went down to 110. That's good. So pupil reactive Glasgow Coma scale, I don't want to go over it because we don't want to take time. Excellent, guys. I agree with you. So then we go down and we see this deformity in the femur. There is a significantly femur fracture, deformity. What should we do for the femur? يلا أعطوني أجوبتكم. What should we do for the femur? Okay, splint. أحسنت يا فاطمة. Traction. أحسنت حسام. Excellent. So why we do? Somebody is saying, why, doctor, you have to do this? As Tahani mentioned, if there is an open wound and there is a bleeding, you have to apply pressure immediately. You don't have to wait until to say exposure. So immediately apply pressure and put a splint and traction. Why? Because so many reasons. First, this will improve the pain for the patient. Okay, if you splint it and make it straighten. Okay, and this will even reduce the tissue damage, because if it is angulated and fractured, this will cause more damage. And third, also this will reduce the bleeding. Okay, so for this important reason, we have to apply pressure and put traction. Okay, excellent. طيب. So what do we do next? This patient, we noticed that he is, even after these two boluses, his blood pressure is not maintained. طبعا C spine سويناها. Okay, it is okay, alhamdulillah, there is nothing. Okay. Okay. The patient, this is his X-ray. شايفين الإكس-راي؟ What is this? Who can tell me? يلا يا جماعة بسرعة عشان بعد الدكتور حمد he's waiting. No, this is after we finish. Yes. Okay. This is fine. Okay. What is your finding in the chest X-ray? Please, guys. Anybody can tell? Hemothorax. Okay. Hemothorax. Actually, there is a left lung contusion. Absolutely. Who this said that? Okay. Hitaf, you are absolutely right. Excellent. Okay. There is a significant contusion in the left side. And this is usually the most common presentation in trauma victims, either adult or pediatric. Okay. They have contusion. Especially when you do CT. Sometimes if we do an X-ray, we didn't find it. Okay. When you do a CT, it is clear. They have some element of contusion. Okay. But sometimes contusion not to the degree that they are hypoxic. Okay. So what should we do then? This is the X-ray. You see the femur. There is a significant fracture, mid-shaft femur. And this is what we do, a traction. Shall we send this patient for CT or we shouldn't, by the way? This patient we mentioned, guys, here you can go back. His blood pressure 90/60. So he is hemodynamically stable. So we can send this patient for CT. And as you can see here in the CT, she has significant lacerated spleen. Okay? Fine. CT brain. Oh, this is a severe head injury. You can see this punctate lesion. Okay? Which indicate there is a significant head injury. Okay? Because I finished already, I took 2 minutes more. So what we should for this patient, what do we have so far? We have severe head injury, we have pulmonary contusion, we have significant spleen injury, and we have also open left femur fracture. So what happened? Okay, this is in periphery. So surgical on-call arrived, and you discussed the case with him and identified that the patient needs to be transferred out to another facility where they have a pediatric surgeon and PICU. Your hospital, they don't have this facility. Let's say like in Nizahmiya or anywhere. This is all happen in the emergency. So you are given fluid, you are given blood, you are doing a traction, you are doing everything for this patient, and you have to arrange for transfer. Okay? So you have to communicate with other hospital and you have to arrange for transfer this patient to another facility. Okay, would we allow one member of the family to be with him? Because this is a common legal question. Yes, we should allow one member of the family to be with him. Okay. So important message here. A case of severe head injury must be intubated and ventilated using sedative and muscle relaxant. Call for help if it is difficult. Pulmonary contusion is the most commonest pulmonary injury in children. Okay, other life-threatening injury takes priority over severe head injury. That's why sometimes you have a significant head injury and it's like a distracting injury and you miss other injuries like femur fracture or abdominal significant injury. Most abdominal visceral injury require conservative management. They don't need like a partial or a total splenectomy or medical transport is a high-risk process. So you have to make sure the patient is stabilized before transport, especially if you think that he doesn't need intubation. This patient definitely needs intubation. But if you are transferring a patient, it will take 2-3 hours, better to intubate. If you are expecting that he may deteriorate on the way to the receiving facility. Okay. So in summary, the management of multiple trauma require good multidisciplinary care. Always apply ATLS guidelines. Okay, primary and secondary. In shocked multiple trauma patient, always look for tension pneumothorax and relieve it immediately. Okay, and most abdominal visceral injuries are treated conservatively. Any question, guys? We'll leave the question if you don't mind, because to the next lecture, because
يعطيك العافية. شكرا دكتور محمد.
الله يبارك فيك. طيب الدكتور حمد, he is with me now and he will present his lecture for you, and you can start, Dr. Hamid, please.
Okay. Okay, this one, share screen. السلام عليكم ورحمة الله وبركاته. Good morning. Thank you, Dr. Muhammad. Screen is clear. You can see my slide?
Yes, I can see your slide. Very clear. You can start.
Thank you. First of all, thank you, Dr. Muhammad, for that introduction, for that how to deal with that trauma patient and pediatric. It is very crucial point you mentioned in your lecture, and you cover and generally many system, and now we'll be focused in a different system to be know how to read and how to interpret that's any image or X-ray, and what you have to do for any patient present to the ER. One of the important part you have to be focused on the cervical. You have to how to clear the cervical if the patient present with the neck trauma, or you don't know, or this patient he has any something need to interfere with this patient, and who deserve to go for immobilization of that neck or not. So in my talk, you will be covering that many important notes about that cervical and what's the etiology and pathology, how can make good differential diagnosis for any patient present to the ER with the cervical trauma, and what's the good evaluation for that emergency department for that cervical, and how to clear the patient if he has immobilization and he has an collar, or and when you have to remove it or not, and what's the diagnostic study for this patient and the treatment. This scenario, this is the briefest scenario mentioned by Dr. Muhammad. This common scenario can be present to the ER, and this other scenario. This patient, 14 years old, present with he is adolescent boy, present to the emergency after he's being ejected from that car. He was boarded and collared at the scene, and the AMS, he bring patient after giving 1 liter of the intravenous normal saline, and he has hypotension in the scene. The blood pressure is 95/50, which improved to 115 after giving the bolus. Patient, when he arrived when arrived for this patient to the emergency, he is very drowsy, and but he's arousable. His vitally sign, his blood pressure is 90/50, heart rate 140, respiratory rate is 18, and oxygen saturation 96, and temperature 36. He's moving. He's no movement of any his limb, and his chest is clear, and his abdomen is somewhat is distended, but there is though he's soft and tender, non-tender, sorry. So you suspect from that presentation maybe there is a spinal injury. So it's very common, can be present like this. So you think about spinal injury and how can clear this patient. He's really a spinal injury or not? Why the change in the blood or vital signs, and also that patient he cannot move that limb. It is any benefit from the steroid or not? what's the how to send the patient, what's the good disposition for this patient, he's there to go for further management or not. So it's very important when you are working the emergency to be familiar for that important point. Pediatric patient, one of that challenging and pediatric patient is not common, and that's a cervical injury. So one of that obstacle for that our reference, no good study you can find in the literature about the pediatrics. So just only 1 to 1.5% of that common trauma can be presented there. So it's not common and not more familiar in the pediatric population. So it's very important to be going to adult reference to depend on that adult reference to build some policy or rules for to how to manage with the patient with the spinal trauma. So the main age of that patient usually with the spinal or cervical spinal injury is 11 years old. You can just only less than 5% you can present with the spinal trauma less than 2 years old. The boy, as you know, is very predominant. Usually from 83, that's only bony structure that's involved more than soft tissue. And other important thing, which spine or cervical spine is important, that's injury. Usually the pathophysiology or that's anatomy of that's pediatric difference in different age. We can define that group into two groups. One group less than 8 years and one group more than 8 years. That group less than 8 years usually they will be present with a different pathophysiology, and the cervical spine usually is the common, the upper cervical spine injury from C1 to C4. Also, that can be find this one in the lower upper lower more than 8 years, the other group. But lower group or lower cervical spine injury is not common seen in the patient less than 8 years old. Approximately 1/3 of the children had neurological impairment, and just only 24 of that neurological impairment he has a complete cord injury. Approximately half of this neurological impairment had no radiological evidence. That's one of the important challenging us, and you cannot find anything in the radiological study in the presentation. So you have to depend on the clinical approach more than that you depend on that radiological study. So it's very crucial to understanding the age related to the physiological difference between that affected the patterns of this injury and radiological interpretation in that children. Also, why it's very crucial, why it's important that spine injury, even this low percentage of that presentation of as a trauma. The important for this one, it is lethal, or this can be cause death, and the mortality is very high, and some cases can be die or can be pass away in the scene. So it's very important. So it's common the mortality is highest in the young children who is present in the cervical spine injury, because most of that age is presented in the upper cervical injury. It's very important to be more familiar about the anatomy for this one. And also, what's the etiology for this one? Etiology, most of that case is present with the motor vehicle accident, and patient is most common cause of injury in children, and sometimes can be present with the sport or maybe his fall from that height. And comparatively, this large head of that body to the body size ratio يعني the head is more large than to body size ratio can relatively weak the neck muscle and ligamentous laxity and absent of an acinated process. Where is the acinated process? This one you can see this acinated process you can find in the more elder patient or in the adult that make more good stability of the spine. So you cannot find this one in the pediatric. So if there is some laxity for this one, and also you can see angulation and for facet joint, and you can see that which vertebral body that make very high risk to cervical injury for the pediatric or small age. Young children, one of the important, he's the fulcrum for this motion of the center of the motion of that cervical is focused on C2 and C3. But in the more than the 9 years old, the motion or movement is focusing on C5 and C6. So that's the make big difference when the patient present the AR if he is present with this one. As you know, this is the it's very important to move for. This is adenoid. This is adenoid or the second cervical, and this is the first or atlas, the vertebra. This is the first cervical. You can see that head of the adenoid, and this is the alveolar ligament is around and make stability of the adenoid. Okay, this is the anterior arch. This is the posterior arch of the atlas. You can see also the transverse ligament of that atlas. Also, you can see it's very important. If you can see this is a occipital joint, you have to imagine how to adenoid make good stability of that C2 with the C1. And also very important to see how large that spinal canal of that spinal cord. If there is any fracture for C1, you can really to find some neurological finding with this patient. The spinal column in the young children can be stretched up to 2 inch without any injury. Where that spinal cord in that adult, you can just only stretch around 0.25 only inch. And that one can be have injured without any finding in the bone structure. So leading to concept of the squara, that one that spinal injury can there is present with the injury without any radiological abnormality cannot be squara. This is common for pediatric or young pediatric age. The development of the cervical spine is essentially is completed at 8 years old of age. So in patient present with the patient less than 8 years old, there is predominant for the axial fracture or axial injury. And patient who is more than 8 years old, the adult patterns that injuries is more commonly it is injury common present with the spinal column for this one. So as mentioned by Dr. Muhammad, this is the first cervical or atlas. This is the anterior arch for this one, and this is the anterior line. You can see the anterior vertebral line, and you can see the alignment for this one, and this is the posterior vertebral line, and this is very important to be see how is the alignment of this one. Spinal, this one you can see the spinal laminar line, this one. Okay, very important to be more familiar about this one. This is the superior articulating facet of C5, and it was very important when you make a lateral view for neck. You have to be see the from C1 to T1 or the first thoracic vertebra. Okay. And it's very important to be more familiar how to interpret this one and how to make good alignment for this one and see can be interpreted this one and to make good assessment for this one. Uh, what's the differential? It's very important. Second spinal fractures is common. That's in adults. Approximately 10% of that adult patient we present with the cervical spinal fracture. You have to looking for other vertebral body. Maybe there is other fracture for this one. So maybe not necessary to be very close or near to that vertebra. You have to search for other vertebral body or cervical vertebral body to be there is any fracture. Spinal shock must be considered in cases of whose apparent complete cord injury and the absence of the reflexes in the most helpful finding. That's can be the absence of reflex can be help to differentiate between the spinal shock and from that true cord injury. So spinal shock causes transit, neurological symptoms, and autonomic dysfunction for this patient. So this patient, he's in shock sometimes. He presents with the shock. He's hypotensive. But in the other hand, blood pressure, sorry, the heart rate is bradycardia. So you see this patient bradycardia, and also this is one of the challenging us if the patient he is intra-abdominal bleeding and he didn't feel any tenderness and he cannot express any pain. So one of important to be think about spinal shock. Any patient he is hypotensive and he's in bradycardia. This one table will be show some of the common presentation of that patient less than age of 8 years old that's present with the he's present in the cervical or the atlas fracture. He's the common injury can be that atlanto-occipital dislocation. One of the serious problem is usually maybe he's difficult to be diagnosed that patient in the ER. So we need to go for CT scan, but it's very serious problem for this patient. So it's very lethal for this patient. High energy mechanism can be by acceleration or deceleration for this patient. Atlanto-axial rotatory subluxation, other one of presentation it can be present, but there's no clear mechanism for that patient how that's happened. But patient he is presenting with the contralateral chin is rotated to the flexion and the neck is copropen torticollis and he's the C1 or the white baby can be find some radiculopathy in the X-ray when you make good X-ray for this one. Sometimes normal, except all this symmetric of distance relatively to the lateral mass if you just make good X-ray or lateral view for this patient. Burst fracture or Jefferson fracture that's in the axial loading that's present with a neurological injury. It's uncommon, but large spinal canal at C1 that's make rarely to find the neurological finding for this patient. And also if that's a fragment of that cervical spine, he will be going outwards. Usually identifying the X-ray, we can see that's atlanto-dense interval between that one. You can see this one if you make good view for this anterior posterior or for this cervical. You can find that's adentoid or open mouth adentoid view. Can see that's more than 5 millimeter to be indicate this is not equal bilateral. So it can be sometimes it's very helpful to diagnose for this one. Cervical number 2 for this patient, fracture can be suddenly epiphysis, so subdental epiphysis fracture for this patient. He has present with that due to the flexion loading, usually no neurological finding, but the problem for this one, that's dense fracture, or this is subdental epiphysis, that his cartilaginous part, so it's not commonly can be figure out by X-ray to diagnose the patient if he has any fracture or not. Dense fracture, this is secondary to the hyperflexion or hyperextension, usually no neurological injury and just only patient present with neck pain. And other problem, he is sometimes can be present with the dysphagia to secondary to retropharyngeal hematoma may be present. There is 2 or 3 types for this one. I will not go through it. It's very tough for this one. If it's superior or the base or the extent to the body of that cervical tube. Other presentation, that's one subluxation between the C2 to C3 or C3 to C4 due to secondary to hyperflexion or hyperextension for this one. This is ranging from a neurological finding to be there is complete motor or sensory loss for this patient. We can see if there is any dislocation between C2, there can be displacement of the body from C2 to or C3 anterior, must be differentiated from that pseudo subluxation. I will mention this one later on. And you can utilize that switch choke, this line. I will be explain this one later on. Other important thing, that's common subaxial vertebral column injury. That's more common in the children that's more than 8 years old. Injuries can be present with the compression, fracture, secondary to the hyperflexion or hyperextension. A patient may be no neurological finding and he lose of the vertebral body height. You can see that's height of this one. To compare that's the vertebral injury, you can see there is some difference when you compare to the other vertebral body. Burst fracture, this one is axial load in this one. If there is any axial load in that neck, can be make cord dysfunction below that level of the injury. Can patient present to can make protrusion of the vertebral body that can make pressure on the spinal cord and our nerve throat for this one, and can be protrusion vertebral body to be anterior and posterior because that's burst fracture and this load that's happen for this vertebral body. Flexion teardrop fracture, other one of type of fracture, can be secondary to the hyperflexion, frequently associated with the cord dysfunction below the level of the injury. Patient may be present with the effulsion of the anterior inferior for that aspect of that vertebral body, and maybe present with the posterior cervical displacement above the level of the injury. Maybe present with the anterior dislocation with the facet joint and flexion or extension view in the can. This is very important. This one you can go for MRI needed, maybe assist that stability of that vertebral body. Spinal process fracture is very important, but no neurological presentation for this patient. Usually in plain radiograph, it can be diagnosed. Other important ligamentous disruption without any fraction can be happen in the, as mentioned, the squara. This can do to hyperflexion or hyperextension, but usually is no neurological deficit. It cannot be seen in the plain film and maybe missed in the CT scan. You can go for MRI if you cannot see anything in the MRI. Like this one, It's very important to know this is spinal cord injury without neurological abnormality. This the flexible nature of that pediatric spinal cord. This can put you in a square. So this is very important. There is a study have also reported there is delay on sometime in myelopathy for this patient between 22 to 27. So is you can think about square for this any patient, even you cannot see any finding in the presentation or in the X-ray or plain X-ray. Atlantoaxial rotatory injury, one other important presentation for injury for that's C1, that's more commonly seen in the children. It is clinically suspected in patient. He is unable to turn his or her head to midline with a spasm of contralateral area. There is sternocleidomastoid muscle. There is a spasm. Patient present with the torticollis. He can present with something you can call the Cock province appearance. You can see in the lateral view of this one lateral mass, we can see this is the C1. This one, the C1, this is the anterior, okay, of the vertebral body. And this is the line. You can, when you make a imaginary line, this one, you can just make or draw this one in this anterior vertebral line, and this is the posterior. You can see there is displacement, or this is anterior displacement of that C1, and this is the C2, okay? So there is some displacement for this one, and there is mass is rotated. This one that's mean he lost that's normal accepted alignment of that cervical. Usually successfully treated with the manual reduction or traction, which should be performed in the spine by spine surgeon. What's the evaluation you have to do for any patient present to the ER? It's very important, the history. History is very important. The primary survey assessment, you have to go for airway, breathing, circulation, stability, and obtain the focused trauma history in the sample format. This is a patient. What's the sign of the symptom? Ask the specifically about there is any neck pain, paresthesia, paralysis, and there is assist of the level of the consciousness and ingestion of this or intoxication. Check if there is any allergy. What about history of the medication? Past medical history is very important. Special attention should be paid for that present with the injury before, or there is any surgery before, or that some special condition can be present with the spinal injury. You have to be considered, and if the patient you cannot clear easily with this patient who is present as Down syndrome, Klippel-Feil syndrome, and achondroplasia, or patient with polysaccharide, Ehlers-Danlos syndrome, Marfan syndrome, or that other disease can be present. Very important and very important to when you clear the patient from this injury, you have to be more familiar with this disease for this one. Last meal has very important to determine if there is a risk for vomiting or during when you aborted this patient, and what's the event leading to that injury as secondary to motor vehicle crash or sport or falls. This one, and when you take this history for that patient present with the motor vehicle accident, you have to details taken from that who's brought this patient to the ER from the AMS or the parent, about what's the speed, how is this ejection, what's there is an history of roll over, or there is seating position, or this patient in the front seat or rear seat, or point to the impact for this one injury to the other. There is death, or there is involvement of the motorized recreation vehicles that can be used in the any park. This one, and there is any history of this present with the bicycle, or this one he is pedestrian. This patient, how is this patient hit by that car? And also it's very important to dig more about the sport, if he's engaged in the diving sport, to rule out if this patient he has axial loading or mechanism that can think about what type of fracture can happen for cervical. His fault determines what height of that fall, a number of the stairs this is descended. It's very important. What about physical examination for this patient? You have this the clearance from that immobilization without radiological investigation. It must be first to clear the patient he is present with no any altered mental status, no any significant or any painful distracting injury, no any focal neurological deficit. If there is any one of that with that patient, you cannot clear the patient from that secular or that clear from that cervical injury. Once this on the general examination has been completed, they had that patient hard collar maybe remove if he fit to remove that one, and it is felt that the patient is maybe try to move. If you feel that patient he will not keep stable, he is moving during that examination, it's better to ask other one or your colleague to hold in line a stabilization of the neck till you are finishing from that examination. Palpate that each vertebra from C1 to T1, okay, from cervical 1 to thoracic, first thoracic vertebra. You have to looking for any tenderness. If there is any midline tenderness, or that patient he's rotated the head to the 40 degree in each direction. If you feel there is some limitation or there is pain with this patient, you have to stop. If there is pain or there is abnormal sensation in the neck movement, no tenderness, you have to be, there is no tenderness. Can you clinically clear that cervical spine if there is no tenderness? It's always viable and very important option for you to wait till that distress of that trauma has subsided and some therapeutic time is has elapsed before that's re-examined the patient and then you can re-examine the patient and to be clear the patient from cervical. If the patient just only your concern, a patient only cervical spine, you can keep the patient in secular and you can just let him to doing his activity as tolerated and you just keep waiting in the waiting area. What's that important consideration in this patient in the physical examination is abnormal motor examination, abnormal sensory examination. If there is any neck pain, torticollis, decreased neck range of the motion, abnormal reflex, clonus without any rigidity, diaphragmatic breathing without any drone. That's brevism for this, or urinary retention, autonomic hyperreflexia, decrease of the or absence of the rectal tone, and abnormal bulbocavernous reflex for this patient. طيب, we'll now going the important part of that's my talk. How can be good diagnostic study for this one? You know how can be labeled this patient low risk criteria for the cervical spine injury? You know that National Emergency X-ray radiography utilization study, as you know, this is applied in the adult, that you can call this a nexus, and the Canadian C spine rule, you can apply in the pediatric. We try to apply this one in pediatric. Two large general study in the national emergency and this one and CCR have to be attempt to identify the patient he is low risk for this cervical spine injury. So the Nexus has sensitivity around 99.6 and specificity is very low for this to rule out cervical spine injury. So CCR for this one, or Canadian, has sensitivity is around 99.4, or specificity is 45.1. Recent systemic review in pediatric 15 study found that similar result for that CCR and Nexus rules. What about Nexus rule? Nexus rule is Canadian spine rule. You have to apply in the patient GCCS. You have to be gas coma score for this patient is around 15. Okay. Our first, very important to know about the mechanism, not high risk mechanism. Able to rotate neck 45-degree right and left. Any of the following. What's the other following? That simple rear and motor vehicle accident. Sitting, you can sitting in the emergency department. Ambulatory at any time. Delay onset of the neck pain. Absent of the midline tenderness and age less than 65. That's mentioned because this started to apply in the adults. So you can try to utilize this one in a pediatric. What's the mechanism, high risk mechanism? That's force from that 3 feet or 5 stairs, axial loading for this patient, or motor vehicle high speed more than 100 kilometer per hour. There is any no roll over or rejection, or there is any history of a motorized recreational vehicle or bicycle struck or collision. Nexus to label this patient with low risk is no cervical spine tenderness, no any significant painful distracting injury, absence of the focal neurological deficit, no altered mental status, no sign of the intoxication. And the CCR for the study is exclude patient less than 16. This is one of the obstacles for our limitation of that study. You can apply for this one, but we will try in the other some literature to apply this one pediatric, see how is helpful for that pediatric. Only 2.5% for patient with the nexus can be where age less than 8 years or included in the nexus. Official, this he is doing conducted a prospective study to evaluate if this nexus criteria in children less than 18 years. He include in his study is around 3,065 patients involved. Around 603 met that low risk criteria for this patient. None of this had documented cervical spine injury. However, we are only 30 injury identified in the patient with not meeting low risk criteria, just only around less than 1% with this one. And only 4 of this injury were less than 9 years old for this patient. Only one study is compared that CCR and Nexus. He found that criteria in children by retrospective assessing children age less than this is one of that obstacle. All the study is retrospective for that pediatric. Age less than 10 years old. That's in cohort 125 patient is with the 7 spine injury. Nexus criteria had would have missed 3 of that injury is around 43, and CCR would missed 1 injury is around 86 sensitivity. The data for this study indicated that general low risk criteria likely perform reasonably when the patient is more than 8 years. Wouldn't be decrease or less than 8 years, decrease that sensitivity and specificity for that to rule out low risk. Other study by Liham, this one retrospective divided the children to apparently isolated to that just only head injury with high risk, and other group is low risk for this one, high risk, low risk and high risk. Low risk group for this patient is one 135. The other group high risk is 133. Why is high risk? He defined high risk defined as an ability to communicate secondary to the age or head injury, age less than 2 years old, and the neck pain. And he found that there is 10 of those injuries, 7.5. He had a high risk group, but no injury were be identified in the risk group. Plain film radiograph for this one. This is adenoid view is unnecessary in any age group, although it maybe have limitation utility in the children less than 9 years old. Also, the dynamic extension, hyperextension, and reflection view for this one. The cervix one, I unlikely to be diagnostic in the setting of the normal static film. The other challenging for that pediatric, when you make good interpretation for that film for lateral view, that's pseudo-luxation, some luxation for this one. So most of the common normal finding and maybe mistaken for that injury, that patient will present with the pseudo subluxation from that C2 and C3, which we found around 22 to 24 for children aged less than 16 years old. The main age is 6.5. What's happened for this patient? That happened because that large occipital and that's in young child pushing of that head forward and related to the body rest. So you can find that when you put in the hard surface, you can see this is a switch shock line. You can see this one. When you measure this one, is more to 2 millimeter. This one, this is the C1 and C2 and C3. Make the line between C1 and C3 and see if there is any displacement also for this one. You can see this displacement. If it is more than 2 millimeter for this one, that's meaning that's maybe his pseudo subluxation. More than this one, you can think about a hangman fracture for this one. Other normal variant for pediatric cervical spine. This is the common normal variant to this are overriding of this anterior atlas in relation to the adenoid extension. This can be found in 20 to patient less than 8 years old. Summer view, this is very important for this one to be familiar for this one. It's important to check for entire cervical spine from C1 to T1. If you find some difficulty, you cannot visualize in the X-ray, you can ask the patient to do the summer view for this one. He's taking that arm close to the plate and raise that over the head, and you can put opposite arm pulled down to keep the humeral head out of the view. Can we about CT scan? What about CT scan? And if there is any rule, yeah, it's very important to be better initial test. If some challenging case, the majority of CT scan can be performed due to the inadequate blame film for that presentation of that pediatric. CT scan is higher radiation dose. There is one study increased that length of that patient in the ER from 183 minutes to 259 minutes. On current evidence, plain film should be remain that initial imaging and of choice. CT scan is being useful for differentiate patient is a condition that remain unclear by after examination by plain film. There are expectation from CT scan if we can roll out or not. No need to be using CT scan to clear the patient and use this patient to lower if the patient he's mustly to do this CT scan to clear the patient. No, if the patient clinically he's well and plain X-ray is doing reassure us that he can clear the patient. There may be exception for that CT scan used for patient who is lower GCS and high energy severity score. So case of this is suspected atlanto-occipital dislocation for this patient, you can go for CT scan, no going for that plain X-ray. You must consider that with the severity of injury patient, that's higher risk of cervical spine injury. You are not CT scan be initial diagnostic tool for this one. Okay, so you have to keep the CT scan your option for if you have major or higher risk motor or mechanism for injury, and don't go for brain X-ray. You have to go for CT scan from the initial presentation. The low number of that injury limit that generalization of this finding in the pediatric. That's one of that important point and challenging us. MRI, this role of MRI is remained this largely outside of the emergency. One area of utility to clearing of the spine in the obtunded or intubated patient ICU, and their cohort MRIs confirmed that film finding in 2/3 of that cases changed the diagnosis. 2/3 can go with the same plain film, but 1/3 change of that plan and management with for that patient. MRI also be rule in the patient with the persistent pain, even negative plain or CT scan imaging. MRI play very important in the squara. We can summarize this important point in the diagnostic study. The imaging should be obtained in children with high-risk traumatic mechanism, patient who cannot be communicate due to the age or head injury, patient who had a neurological deficit or neck pain or painful distracting injury, patient who have altered level of consciousness or secondary to head injury or intoxication. Children aged less than 3 years with either high risk mechanism, motor vehicle accident, or patient fall from 10 feet, and non-accidental trauma, GCS score more than less than, than 14 should be having imaging. Cervical spine imaging should be consist with the AP and lateral and odontoid plane radiograph, with the understanding that lateral view is the most helpful, and that odontoid view may not be useful in the children aged less than 9 years old, and flexion and extension view are unlikely to be helpful for that in sitting normal static radiograph. CT scan is not necessary to clear the cervical spine and should be reserved for that investigation for specific area or concern or focus imaging. Exception for this would be patient on the multi-system trauma and patient with the suspected of attentoid occipital dislocation. In cases of this concern regarding the squara, you have to go for MRI for this patient. What you have to do for initial treatment for this one? Identify the spinal cord injury. You have to be lie in the secondary survey. Although cord injury and immobilization have to be impact on the primary survey. The priority of the treatment remain that airway, breathing, circulation. What about intubation for this one? This is one of that important point. If the patient with a cervical spine injury and you go for intubation, it's very high risk for this procedure. You have to be immobilize the patient during that intubation. Spine immobilization can be maintained by the rigid cervical collar or by second person providing in line stabilization during that procedure of that intubation. Circulatory assessment of that compromised patient, because that's occult bleeding. That's one of important. If the patient present with the cord injury, sometimes he cannot feel any tenderness in the abdomen, so he's hypotensive, but he not express any bleeding or tenderness in the abdomen, but he's active bleeding. So secondary to the cord injury or spinal shock, especially in that patient who present with the injury to the cervical. Management of that shock patient, neurogenic shock, that's injury need to be loss of the sympathetic tone and heart and vascular system, causing this patient, he's present with a bradycardia, peripheral vasodilatation, combined by that effect decrease that vascular tone, so decrease the cardiac output and significant drop in the blood pressure. So you have to give fluid for this patient. You can start the patient in vasopressin and tropes. That's working in the alpha and beta adrenergic. That's like dopamine or norepinephrine. Sometimes it's not recommended to start patient phenylephrine. That's one can avoid it to and avoid that's alpha effect that maybe can cause bradycardia for this patient. So you have to be avoided. Pain management is important to give good analgesia. It's very important and crucial point in that presentation of that patient, but you have to be not non-avoid analgesia. When you try to still not clear the patient, you have to do clinical examination for cervical to rule out cervical spine injury. What about the steroid? Steroid is very some studies showing that's important of that can speed on the recovery and promising and preclinical study. But that's some cases because that patient because that steroids remain that controversial issue in adult, and there is no good there is no study in the pediatric group, so you cannot consider as a standard for care at this time. Obtain expert consultation with the spine surface to considering that administration of that steroids. What about the surgical consultation? Isolate non-displaced spine process fracture should be managed in conjunction with the orthopedic or neurosurgeon. If there is any neurological deficit, that consultation should be occur on the emergency basis, and that there is some evidence in that in adult early surgical intervention decompression will be improve the outcome. Treatment of square is very controversial issue. Some author recommend to use bracing for 12 weeks, and the other indicate to bracing does not be affected in the outcome. Out disposition of this patient. Patient who met that low risk criteria for that spinal injury can be safely discharged the patient home without any precaution or scheduling follow-up for this patient. The presence of the spinal fracture or any neurological deficit require consultation with the surgical spine surface. An isolated non-displaced vertebral spine fracture, which we should be reasonably to be treated symptomatically and with the follow-up with the surgical surface. Visits of the midline neck tenderness and or decrease range of the motion, you have to consult the neurosurgeon to determine the optimal disposition for this patient, and MRI may be needed for this patient. Prolonged immobilization sometimes difficult for pediatric less than 8 years, so he need to go for follow-up with the neurosurgeon at early appointment with the OPD. Spinal cord injury make up very small percentage for pediatric patient. And when this initial test revealed that potential injury, more advanced imaging may be needed for this patient, CT scan or MRI, very important establishing and definite diagnosis for this patient. The emergency clinician is take that identifying that injury and providing that initial treatment and stabilization, but definite management of this injury is like in the outside of our scope of that practice. So it's very important to involve the neurosurgeon and spine surgeon for this patient to involve for this any case if there is a suspicion of that injury of that to the cervical. Once this injury is identified, managing decision should be made in the conjunction with the surgical spine service. Medical management consists of that proper general trauma care with emphasize that spinal precaution and adequate oxygenation and aggressive blood pressure maintenance in hope to limiting of additional spinal cord injury. Thank you. Dr. Muhammad.
Thank you very much, Dr. Hamad, for this interesting and detailed presentation of pediatric cervical spine injury. And I would like to welcome also Dr. Saleh Al-Shehri, who just recently joined us. For the next presentation, I'm going to talk about head injury in children. I hope this is the... Can you see the Can you see the slide? Okay. As you know, head injury, it's almost a daily presentation to our emergency department. And most of the time, luckily, it is like minor head injuries. But this is the most difficult one to deal with, the minor head injuries. However, sometimes this minor head injury may go into moderate to severe head injury, which is like a nightmare for the emergency physician. That's why sometimes we are abusing doing a lot of CTs where it's not indicated, okay? And for this reason, okay, I'm sorry. Is it now clear? Just to give you an idea about epidemiology on head injuries, in younger children, most of the time it's falls are the leading cause of head injury in children, especially the younger age. Also, motor vehicle crashes can result in death sometimes, secondary to head injury, up to 31.8% among all age group. Male usually more than female, because we know they are more hyper and active. And we should consider shaken baby syndrome in these cases, okay? Especially in children where the history and the examination is not compatible. So this is very important. As we know, this is clear that head injury account annually for, this is in the USA, okay, 3,000 deaths and almost 30,000 hospitalization and 473,000.9, almost 474 ED visit in US in children younger than 14 years of age. So, what is our primary goal in managing head injury? This is a very important question. Okay, it is just to treat for to prevent the secondary brain injury. What is secondary brain injury? Can somebody tell me? Usually that we should prevent. Okay, significant increase in intracranial pressure. Okay, bleeding, causing herniation. Okay, what types of head injury do we know? Usually, see your answer. Okay, neurological deficit, open damage, hypoxia, hypotension, hypothermia, neurological deficit. Absolutely right. So what types of head injury do we know? There is so many types, okay? Sometimes based on the pathology itself, sometimes based on the Glasgow Coma scale, and there is so many types. For example, like Glasgow Coma scale, okay, from 13 to 15, we consider it mild, which is the most common, 80%, and moderate, 10%, severe, 10%. Okay, the most difficult one, really, for the emergency physician is the mild one. Okay, when I have a patient with moderate head injury, it is easy for me how to manage it, okay, or severe head injury. But when you deal with mild head injury, it is like, as I told you before, it's like a nightmare, because this patient may come back to the emergency with significant, neurological deficit or significant problem. This is also based on the pathology itself. Either it is open head injury or closed head injury. Okay, there is another classification. Okay, so we'll start as usual by cases, okay? And we'll see the first case. This case is a 12-year-old boy who slipped on a wet surface. He lost his consciousness for 3 minutes, and he was brought to the emergency department 1 hour later. On initial assessment, he had normal vital signs, and his Glasgow Coma scale of 14 out of 15. A detailed physical examination was normal, apart from a small occipital contusion. So what you will do for this patient, please? Can somebody tell me? How you will manage this patient? Okay. Observation, observation, observation. CT, okay, CT, CT. Okay, let us see what they will do. Mild head injury. Is there a rule for plain film X-ray in the assessment of acute mild head injury in the emergency department? Fatma, she said no. Alia, she said yes. CT by B. Karen. B. Karen. Okay, Alia, she said B. Karen. Okay. So if you are dealing with mild head injury, this is usually, guys, it's very important. If we stick to this, what we call it, the guidelines. There is so many guidelines, more than 3, 4, 5 guidelines following, and most of the time we are following BCARN. Okay, BCARN, and but it depends. I can assure you, okay, on the decision to do a CT or X-ray. It's made on the observation, okay, and for the physician himself who's seeing the patient, because there is some physician who's experienced and he has like, feel like this is very unlikely to have any significant injury, and he observed the patient and he will say there is no need for CT. My question here, do we have to do, is there any rule for X-ray in head injury, mild head injury patient? There is no rule, absolutely. Most of you said there is no rule, and it's not anymore recommended. Okay, as it's been mentioned in literature, skull film radiograph are not recommended in the evaluation of mild head injury. Although the presence of a skull fracture increases the likelihood of intracranial lesion, its sensitivity is not sufficient to be useful as a screening test. Because sometimes you do X-ray and there is a suture in the skull, and it may give you a false feeling like this is most likely a fracture. Okay, indeed, and sometimes negative finding, and even you do a skull X-ray and there is no finding, okay, and sometimes it may mislead the clinician or the physician. Okay, you do an X-ray, oh, there is no fracture, no debrisical fracture, and the patient, he has intracranial bleed because Simple X-ray, it won't show the bleeding or if there is any kind of bleeding. I didn't understand your question, Zahra. If you can, this finding, what kind of finding you are talking about? Okay, at what age group? I didn't understand your question. Okay, suture. Okay, yeah, this is in the for example, once more than 1 year, 2 years of age, okay, the bone ossified already, and there is multiple suturing, sagittal, coronal suture, and sometimes it can, if you see an X-ray of the head for a child who's 2 or 3 years of age, you can see multiple, and you cannot tell, is this a fracture or this is a normal suture? Like, what is the indication of CT? As we mentioned, we have so many guidelines. The one we are using most of the time, we call it PCARN. PCARN, this is like the Pediatric Emergency Care Applied Research Network. This is the abbreviation. And it's been used in a huge number of patients, more than 30,000. And they noticed that it is considered to be an accurate. Okay, the sensitivity, it's in less than 2 years of age is almost 100% with the negative predictive value. And more than 2 years, the sensitivity is around 97% with predictive value also almost reaching 100%. So if we follow the PCARN for this patient, I think because he has a loss of consciousness for 3 minutes, which is considered prolonged. So we can we consider to be on the safe side to do a CT for this patient. But this patient, he presented to the emergency like 1 hour later. And 1 hour later, and he has no symptoms whatsoever. So we may also, somebody who's expert physician say, I may observe him for further like 6 hours. And if there is no more problems, I will send him home without even CT, which is also acceptable. We'll go to your, I'll answer you, Fatima, okay? For your question for those very young age, okay. Right. Indication for CT, as we mentioned, Glasgow Coma Scale, okay, less than 15, 2 hours after injury, continuous. Neurological deficit, open skull fracture, signs of basal skull fracture, like this one, okay, mastoid, battle sign, okay, and signs of vomiting more than 2 episodes, extreme of age, like less than 1 month of age, or those who are more than 60 years of age, because this is a fragile age and easy to have bleeding. So you have to consider doing a CT, okay? Retrograde amnesia, he didn't remember what happened, okay? And severe headache. Well, this is very important, okay? This is for children more than 2 years. This patient was 12 years old. I think if you have one of these, I think it should be considered to do a CT, okay? What does it mean if you have this battle sign behind the ear? What does that mean in head injury child? Excellent, Abrar. Yes, basal skull fracture. There is an interesting question, Turkey. What about family request? Okay, this is very important, and we usually see it in our emergency every day almost. The family, they were asking for CT, and I will give you a very interesting story. Especially for the one who asked for very young age, below 1 year. Below 1 year, usually when they have a head injury, you have to be careful with these patients because they are fragile and they may have concern. And you should know what is the mechanism, and you have to examine the patient thoroughly and very, in details. I remember there was one VIP patient came to our emergency. And the whole family, they came with their physician and the private physician. They have a physician at home also. And they were, their child was almost like 6 months old. And she fell, according to them, on the ground, on the floor. Okay. And the floor was marble, like it is marble tile. So it is a hard floor. And their physician, he came and he's requesting CT scan. Okay, so this is a true story. Okay, and I think it's very important for all of you to please, and you have to hear clearly. I check the child. She is playing in her mother lap. Okay, and she is moving all her extremities, lower and upper extremities, you know. And I check her head, and there was no swelling, no nothing. Okay, and the nurse or nanny who's taking care of her, she said, I went again because the history is very important. I went again to the nanny and I told her, how did this happen? She said, well, I've been giving her a shower, and then I took her from the shower and she slipped through my hands and she fell on the ground. I told her, did she hit her head first on the ground, or she fell on her side and then at the end she fell on her head? She said, no, I think she fell in her legs and then on her side and then she hit her head on the ground at the end, on the floor. So I told her, okay, I didn't find any obvious, to be honest with you, swelling or any bruises or any signs of head injury, even minor head injury. The doctor was there standing next to me and he told me, doctor, please, we don't have to waste our time by asking so many questions. We need to do CT. So I told him, well, listen, where is mother there sitting, grandmother, sisters, everybody, because this is their first baby. So I told them, okay, we can do CT, but you have to understand that we are going to sedate her. We should make her to sleep, because 6-month-old, she cannot control herself in the cylinder of the CT machine. Then he told me, how come, no, we don't need to sedate her, we can hold. I said, no, she is 6 months, she will scream when you put her, you know. So the mother, she started thinking, doctor, is it, there is no other way? I told her, no other way. Okay, because we cannot repeat doing CTs, especially if we know that CTs, the amount of radiation is very huge. So now the tone start to change from the family, because the family, they were coming to do CT. This is for Dr. Turkey. What about the family request? So it depends on you. Okay, so if you think this patient need a CT, because as an expert physician who've been doing like pediatric emergency for almost like 20 years, okay, and seeing these cases every day, okay, you can tell and you will be in charge and you will be responsible for this patient. Okay, because if you have any doubt, let's say the patient, she has a poor intake, her activity, she is sleepy, then I shouldn't discuss with them the role of CT. I should tell them, yes, she needs a CT, we have to put a line and we have to give her something to make her sleep, and then we should do a CT. But if you feel like she has, how many times our children, they fell on their head and we didn't even bring them to the emergency. Okay, so yes, we should follow the be calm protocol, but still you should use your judgment. Okay, this patient, I told them, they told me, okay, doctor, what do you like to do? I told them, well, as long as there is no bruises, no signs, and she is playing and smiling, and we need to observe her for like 6 hours in our emergency. Okay, and you can feed her, you don't have to prevent her from sleeping. Okay, let her sleep, but just observe her breathing, and she should stay with us in the emergency till she completes 6 hours. The family, they agreed. So after 2 hours, they left the emergency. They didn't stay in the emergency. They said she is very fine and she has her milk and everything. She didn't vomit and everything. So this is why you have to use your judgment. Okay, for the one who was asking me less than 3 months, you should examine the patient. You should see, and very important, the mechanism of injury, that she fell and her head directly hit the floor with her head, even if it is half a meter. This is considered significant. But most of the time, our children, they fell on their side and then they fell. This is, I think, answer most of you. Okay, let's go to the next. Next case. You are evaluating a 2-year-old girl who fell off a swing and hit the back of her head on the dirt. في السفلت يعني في الأرض approximately 3 feet below. She lost her consciousness for only 20 seconds, cried and was consoled by her parents. And she did not vomit, and her parents say that she seems to be back to her usual behavior, back to normal. So, what do you think, guys? What shall we do? This is her examination. She has a 3 centimeter occipital cephalohematoma without step off and not depressed fracture, no laceration or abrasion. Her vital signs were normal. Okay. Glasgow Coma Scale 15 out of 15, and she has no neurological deficit on examination and cries, okay, when you approach her, and she does not appear to have any other injury. What you should do, guys, for this patient? Yes, she lost her consciousness, so she should have. Okay, observe, 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 observe. Yes, yes. Okay, so some of you, they said because she lost her consciousness for a few seconds, we should do. I don't think this is right, okay? Especially she is back to normal. So there is no rule for CT in this patient, okay? Even if she lost her consciousness for a few seconds, because she is back to her normal, okay? Thorough history and appropriate physical and neurological examination, observation in the clinic. This is what we should do. Office emergency department or at home under the care of competent caregiver. Yani, for example, if they are living very far from the hospital, we should keep them in the hospital, okay, for almost 6 hours. The use of cranial CT, skull radiograph, or MRI is not recommended in this case. Is that clear? So this is what we call it, like DCAB, okay? Head injury less than 2 years, okay? What is the predictor of clinical importance? Okay, head injury. Yani if they have this, you may consider to do a CT scan. And if none of this appear, so very unlikely to have a significant head injury. Okay, so if they have altered mental status, which is still there, okay, or significant scalp hematoma, loss of consciousness. For example, some of you, they said, because of loss of consciousness, I will do CT. Nobody will blame you. I will tell you. You want to be a safe doctor. That's okay. But for me, as a senior consultant, as a pediatric emergency physician, I've been doing this for many years. I wouldn't do it, especially if I do a proper examination and taking a proper history. Okay? Then, if there is no severe mechanism of injury, what do you mean by significant mechanism of injury? Ejected from the car, significant car accident, and the patient was ejected from the car of like 2-3 meters, or there is a death in the car. Somebody died in the accident, so that means, or there is a palpable skull fracture, or acting abnormal according to the family. So this is the history. It's very important. If none of these were there, or none of these were significant to me, so she is very unlikely, or he is very unlikely to have a high or a significant head injury. Okay, and this is the sensitivity and the specificity, usually 100% for those less than 2 years of age. For those who are 2 years and above, I'm talking about the PCARM, okay? Also, altered mental status, loss of consciousness, history of vomiting, very important, frequent vomiting, severe mechanism of injury, signs of basal skull fracture, and severe headache. Severe headache, this is very important because children less than 2 years of age, very unlikely to complain of headache. They are sleepy. But those who are more than 2 years, if they have a significant headache, by the way, in the emergency department, we noticed that they are always coming, okay? And the family, you have a headache? Yes, I have a headache. And he is moving his head to both sides. If he has a significant headache, he will not be able to move his neck because any movement, this will create more headache and it will be a more severe headache. So this is very important, okay? I remember one patient who came to the emergency. That's why sometimes we are ignoring the headache, okay? They came to the emergency and complaining of severe headache. Okay, he's like 25 years old. And the AR physician, he told him that you don't have anything. This is mine. Okay, just take Panadol. And they gave him Panadol, discharge him. The next day he came to the emergency. They saw him again and they told him, well, you know, most likely this guy, because he is like working, he's a pilot, military pilot. I know him very well. He was our neighbor, living next door. He came the second time to the emergency and they told him, you know, this guy, because he needs a sick leave, but we are not going to give him a sick leave. And we told him, and he's holding his head. He is in severe pain. Okay, they discharge. The next day in the morning, his mother tried to wake him up. He is dead. Okay, there is no head injury, there is nothing. So most likely he has some sort of this kind of AV malformation. Guys, when we have any patient coming to the emergency, either adult or pediatric, and you feel he's holding his head and he has a severe headache, and I usually ask them, do you have like this headache before? If he said yes, so most likely, you know, most of our population, they have headache, to be honest with you. Okay? But usually this mild headache, it comes and goes. But when they come and they will tell you that, doctor, listen, this is the first time I have a headache severe like this degree. So I should take it serious. Okay? So this is very important. Okay. So if none of these available, like altered mental status, loss of consciousness, history of vomiting, severe mechanism of injury, signs of basal skull, and severe headache, none, so very unlikely to have a abnormal or significant head injury. So what is the initial assessment, okay, of the child with minor head injury? We know that 2 to 5% may require neurosurgical intervention with those mild. That's why I told you it is really difficult, okay, especially for those who loss of consciousness less than 1%. يعني almost 95 to 98% they are normal. Only 2 to 5%. This is, we consider it serious. But this you can eliminate it by proper history and proper examination. Okay? Although history and appropriate physical and neurological examination should be should be performed. Observation in the office, clinic, يعني what we should do. Okay? And usually I try to be on the safe side. I told them you should stay in the emergency as per American Academy of Pediatrics guidelines. They observe them in the emergency for 6 hours. Okay, I know after 2 hours they feel and they will leave, so it is okay. I will write in the notes they left, okay, under their responsibility. You don't have to ask them to sign against medical advice and these things. Okay, if your hospital is mandatory to do so, go ahead and do it. Okay, because you know in your heart most likely he's fine, but you don't want to take a risk. He could be one of those 2 to 5%. Okay, so he will start having symptoms and signs within the first 6 hours. I mean, let's say if he starts dripping, there is intracranial bleed, and he starts just drop by drop. By 6 hours, he will have a significant headache, and he will be symptomatic. CT scan, cranial CT scan may be used. in this, like less than 1 minute, may be used, but it's not mandatory. And the use of skull radiographs in the initial management of children with minor closed head injury and loss of consciousness is not recommended. This is in literature. Okay, so skull X-ray, if you are forced to do skull X-ray, do CT, please. Okay, and we should give what we call it like instruction to the family. Okay, so let me now. This is what I have mentioned now about the decor. Okay, but let me go back to your question now. Yes. Headache. That's right. If he is saying this is the most severe headache I ever felt, go ahead and do CT. Less than 2 years loss of consciousness, yes, it is significant, but sometimes the family, they interpret it as a loss of consciousness. It's not a loss of consciousness. He is already like he's having like what we call breath holding spells, stop breathing because of the shock itself. Okay, and then he starts crying. So this is just a few seconds. Okay. What I know, doctor, is impact seizure, brief seizure, and return back to normal. Concision, concussion is not for CT, but how much will be safe for brief loss of to keep for observation and not for CT? Dr. Alia, as I told you, okay, this is a common sense, okay, and we feel we are logic when we observe the child. What is the idea behind observation? I want to avoid giving radiation. Let me tell you one thing. Sometimes I have some, as some of you said, doctor, if the family keep requesting to do CT, okay, I will give them the negative side of the CT. For example, I will tell them, CT, each image of CT, it's equal to 400 almost X-ray. So the amount of radiation is very huge. Okay, and this is true, especially in the younger age group. Okay, compared to the older age group, because their brain is very sensitive. So if I feel like I don't want to do it, I have to go to this direction. Guys, I don't think she needs it, because the radiation, the amount of, if I have any doubt, I will go ahead and will tell them that no, we have to do it. Okay, so as Dr. Muhammad Hazza mentioned, it is depends on the clinical scenario and clinical examination and the history and physical examination. This is very important. Okay, it brief seizure indicated, yes, sometimes seizure, it's one of the indication to do a CT. But the family, they may say he is seizing. Most of the time, he is not seizing. He just got panic and stopped breathing and his eyes open. Okay. And this is very common presentation to the emergency. But if you look at him and he's completely back to normal, okay? Because why we are doing CT? To make sure there is no bleeding. If there is ongoing bleeding, his condition will continue to deteriorate. He will not improve. So this is a common sense, guys, please. Okay? Can we go to the next case? And by the way, أنا الآن sometimes I know it's a headache. This cases presented to the emergency for some of our physicians, but for me, I feel comfortable, really. I wish I can see all the, because when you reassure the family and you explain to them and you give them clear direction, if he starts vomiting, if he starts behaving abnormal, if he starts doing anything, just come back to the emergency. He will not die immediately. Nothing will happen immediately. Okay? So this is very important. Sometimes the family, they said, he hit his head in the ground and there is some swelling. And then the mother, she said, he fainted. Okay, and then you notice that he is not behaving well. You go ahead and do CT, because sometimes we are afraid of epidural, which is we call it the arterial bleed. Okay, so there is, it depends on the scenario and it depends on your examination. I'm seeing so many cases and I don't know, I don't do for them CT. Okay, let's see the third case. This is a baby who's around like 3 months. Someone was asking about 4 months or 3 months. How do we do a CT for head injury? Of course we do. If he is clinically symptomatic, okay, and the history is significant. But if he's like the case I gave it early, I told you this patient, the VIP patient who came and he was requesting his physician to do a CT. They left the emergency and the next day we contacted them. They said, no, she is behaving like normal. Thank you, doctor. And they are very grateful. Okay, like some of you, they said, doctor, maybe this will be one of the 2 or 5% who has significant neurological. That's why I can eliminate this 2 to 5% by proper history taken and proper examination and proper observation. I hope this is clear, guys. Like, this is 4 months old, was brought to the emergency department. His parents reported he was vomiting after meals, sleeping more than usual, and lacking motivation. And it sounds like the history, he has a viral infection, but they don't know. They are afraid that she may fell down or something happened because nanny with her most of the time. 11 days later, the child was still having the same symptoms and was brought to the emergency, dehydrated, and she looks sick. And her Glasgow Coma scale 12. So this is, we call it moderate. 13 to 15. This is mild. Less than 13 to, I think, 9. 9 to 13. This is moderate. And from 9 and below, this is severe. So what do you think? يلا يا جماعة قولوا. I need you. What should we do? What do you think? Should we do a CT for her? Abrar, she said labs. Okay, this is very, and no CT. History and examination. I like. Yes, your answer, Afnan Musawi. Excellent. Yes, proper history and proper examination. And ask, yes, Anna Paula, she's right. We should ask to take more information from the parents. What about vital signs and examination? Yeah. So what do you think? And how we manage this patient? Yes, skeletal survey, if none, accidental trauma. Abuse, who's this? Muhammad Zain, mashallah alaykum, Muhammad. You are right. I think we should consider this. Yeah, this is very important. Razan, you are right also. We should do a proper examination, vital signs, and skeletal survey, as Tahani mentioned. Okay, so this is the CT. What do you think? What is this? You tell me what's the finding. Excellent, Fatima. Yes, subdural hematoma. Okay, so what do you think? Yes, all of you are right. So what do you think? They deny anything, okay? Non-accidental. Abuse, shaken baby syndrome. Guys, we should consider this. It is becoming now more common. It's not that very common, alhamdulillah, like other areas. But you have to have a high index of suspicion, especially if the history is not clear. The family, they give you very poor history, and they are sometimes giving you this information that is not compatible with your findings. So you have to think about, okay, child abuse, especially if the parents or there is a new person in the family, like nanny just came, and both the father and the mother, they are working outside, and this is very important. And we have so many incidents, I think you remember in the media about these cases. So shaken baby syndrome, it is very important, and it is preventable. You may save the life of this patient. I remember one patient also, she came so many times to our emergency. First time, second time, third times, and the fourth time she came dead. And when we expose her body, we noticed there is all the fractures, all the bruises, all everything. We did a skeletal survey, so we made a big mistake by not, detecting this case in the previous visit to the emergency. So this is very important. As a nurse, as a physician, I think this is very important. I should be very careful. Okay, and I should, if I'm in doubt, I should alert the scan team, child abuse team, and most of the time you don't have to be 100% sure. And this is what they are saying all the time. If you have any doubt, just call the child abuse on-call team, and they will take care. Okay. And not necessary, they won't tell the parents, well, this is Dr. Al-Fayfi or Dr. Hamad Al-Madi or Dr. Salih Al-Shehri who called us. No, no, no. They will come and they will sit with the family and they will ask them like questions, and you are doing this kind of visit. Okay? And most of the time, not most of all the time, this patient should be admitted, even if he is stable. Because you don't know. He may be like this patient. He will come back to the emergency dead. So it is a preventable and often severe form of physical child abuse resulting from violently shaking an infant by the shoulder, arms, or legs. Okay? And shaken baby syndrome may result from both shaking alone or from shaking with impact, such as slamming a child against the wall. Okay. At least one of every 4 babies who was violently shaking died. Yani 25% they died. That's why, guys, we have to have a high index of suspicion, and we have to open, our eyes and think about shaken baby all the time when the history is not compatible and clear, and you are having any doubt. For example, I see patient, the mother, she said, "Oh, doctor, she is not moving her leg, she's not moving her arm. For how long this? Well, this is for 1 month." This is very bad. And why you didn't bring her? Well, we are busy, doctor. And then you start taking question, and you feel that when you approach her, she is scared, she is sick, looks dehydrated, there is the family, they are not taking a proper care of her at home. Like, nearly all survivors of shaken baby syndrome, they suffer serious health consequences, including mental retardation, developmental delays, cerebral palsy, severe motor dysfunction, blindness, or seizure even. That's why it is very important to pick up these cases as early as possible. The forceful shaking that causes serious shaken baby syndrome does not happen in normal play. Claims by the parents, that a highly traumatic internal injury that characterizes shaken baby resulted from a short fall of a bed or sofa. The family, just to give you a story. One of our security, he told me that, doctor, my child, she has a rash in her face. Just we noticed it yesterday. Her mother, when she came back from work, she noticed it in her face. I told him, you can send me a picture of the rash. Let us see it. He sent me the picture. I saw it on the cheek, on the face. And it looks like a burn with a very sharp edge. ما هي السم الراش اللي نشوفها. ايش هذا؟ قال والله ما ادري، طلعت اليوم. قلت له do you have a housemaid at home nanny؟ قال لي عندنا. So I told him, no, I think you should bring the patient. Bring her to the ER. They brought her with her nanny. I told him, you can come, all of you come. I didn't tell him anything because I don't want to tell him something, then he will go and kill this nanny. You have to make sure first. So they brought the child. My goodness, it is very clear, like she is using the iron. the one we press the clothes, okay? She's put it in her face. This poor girl, she's about like 3 years old, okay? And then I called the child abuse and I told them I have a doubt. And then they made the investigation and it turned to be really, it is true. This is the nanny who is doing this for the child because she keeps crying all the time and she didn't give her, rest according to her. So this is very important. When you have any doubt, okay, and some of you, he's coming with a significant injury, okay, and he's telling you, well, he was playing and he fell down. Excuse me, the history is not compatible with the physical findings, okay? Shaken baby syndrome, it's very important, guys, and I think you will not, I remember this patient who came the third visit. I was there seeing the patient. I feel that night I didn't sleep, honestly, because I feel it's our mistake. We should pick up this case early, okay? So any infant or young child who present with a history that is not consistent with the presenting signs or symptoms, you have to suspect the shaken baby syndrome. And the presence of new adult in home, this is also suspicion, or history of delay in seeking medical attention, they are coming late. Okay, this is also considered denial. Okay, previous history of suspicion of abuse, the absence of primary caregiver at the onset of injury, like both parents, they are at work, and physical evidence of multiple injuries at varying stages of healing. So you have to explore the whole body. Okay, and unexplained changes in neurological status, unexplained shock, and cardiovascular. There is no good, clear history. Okay, so the management, we have to apply the same thing, ATLS, okay? Airway, breathing, circulation, exposed, and then disability, and exposed, and look for other injuries, okay? And ask for skeletal survey, very important, ophthalmology, and also we have to do full labs, and CT should be considered. If you suspect child abuse, then call security and the child protection team. Actually, in our society, we don't call security, we call the child abuse. Alhamdulillah, now we have a child abuse team in every hospital. Okay, and this the child abuse team, they have like a, they have a protocol where they can involve security later on, whatever. So you are out of this problems. Admission should be considered for any child, even if he is healthy. Okay, any child suspected child abuse should be admitted. Okay, you should consult the child aid or society or the child abuse committee, whatever, on call, and they will admit. Usually, this is the plan. So now, before we finish, so remember, shaken baby syndrome. It's very important, and it's a preventable public health problems. Yeah, you could save a patient life, a child life. Okay, and the emergency physician can help to prevent it by asking the parents how they are coping with the with the baby, and how they, is there any distress, anything. I remember one case also, it was in National Guard. That was a few years ago. The father, they brought this girl who's like 8 years old. They brought her, she has a femur fracture, both bilateral femur fracture and leg fracture, and multiple bruises in her chest. And I told her, the mother, what happened? She said, her father, he lost his money in the stock market that day. And his girl, when she came to the home from school, they noticed that she has she wet her clothes, and I think she pees on herself. Okay, so he took her to the bathroom. He said, you should do it here, and you shouldn't. And he started beating her. Okay, they called and then he left the house. They called the 911, and they came and they brought her to the hospital in very bad condition. And even in the news, they talk about it. The guys, you have to take the history and you have to consider other social life. Okay. Any question, please? I think we are on time. Any question for the previous 2 lectures that I did? Okay. Or comment? طيب. If you have any question or anything regarding our lectures, this is my account on Twitter or X. And at the same time, I would like to announce we are having a big conference, and I would like you all to attend it. This will be in April. You can write it down, 23 to 25. This conference, it is an international conference in pediatric emergency medicine. It will be presented by the American Academy of Pediatrics and American College of Emergency Physicians. They are the ones who will come and present all the topics of this conference. I wish you can attend. We usually attend this conference in a state, and we paid like around $900. It's about like 300 something, 340 for physician and 230 for nurses. And it is about 24 hours, okay? Accredited by Saudi Council, and also it is accredited by the American Academy of Pediatrics by CME Awards from their society, and also by the American College of Emergency Physicians. We will announce this in our website. And لا لا it is a real. It is a real. In dollars, the same time with the SASM. Yes. Well, those who are interested in pediatric emergency, they can join. Okay. And you will see the difference. Okay. Any question, guys? You're welcome, Caroline. Thank you for the compliment. Our pleasure. I didn't know what we have. Check.
Thank you,
Yes.
Doctor. Thank you, Doctor. They will go for a break or not?
Let us see. We'll take their, it's up to them. It is a break time. Okay. The agenda, I told them to send it to you. Omnia, please kindly put the agenda or the lecture of today and tomorrow on the screen. Now, please. Okay. And if you like to continue, we will continue. If you like to have a break, what is the time now? It is okay, 9:40, which is, oh, 10:40, I'm sorry. So we'll start at 11. Is that okay with you? Okay, so we'll start at 11. So we'll start at 11. Dr. Hamad Al-Madi, he will talk about ultrasound in trauma child, and also he will talk about cardiac trauma in children. And then we will go for another break and prayer and lunch, and then we will start wound management and dental trauma and ocular trauma. And this is the end of today. Okay? If you have any questions, you can send it on the question and answer, okay, or even in chat. But question and answer, it will be better because we can see it quickly. Thank you very much. Most welcome. We'll come back at 11 o'clock sharp.
But now We'll start now the second session for this our course. We will cover my talk thoracic and cardiac trauma, and after that, after this topic, I will have to go through the ultrasound, how to utilize the ultrasound for detecting fluid, and you can utilize in the trauma cases. In my talk, in cardiothoracic trauma, you can cover the most important thing related to the cardiothoracic trauma and what's the mechanism of injury, type of the chest injury, and we can covering the pediatric and anatomy, what's the difference between anatomy and physiology in than the adult, and pre-hospital care, what you have to do, and the emergency department evaluation, emergency stabilization, and clinical decision of that patient to identify the chest trauma. And you can, at the end of that talk, you can talk about some injury related to the cardiothoracic, and then we can show some video related to some procedure you can do for some patient. As you know, the serious thoracic and abdominal injury in children often are reported as isolated incidents of that trauma in unusual or dramatic type. Failure to recognize this is injury can be an accurate appraisal for the stomach maybe result in an adequate or tardy treatment, as is mentioned by Dr. John. It's very important. It's very important. Don't we delay that management of our patient or discover there is any trauma to the thoracic or abdominal trauma. So some scenario or management is depend on how to discover that one early and how to interfere with this patient and manage. This our patient is 4 years old boy. He is brought to the emergency by the AMS after his high-speed motor vehicle crash with where he was in an restrained rear seat passenger. His vitally blood pressure is 70/39, heart rate 155, and respiratory rate is 40, and an oxygen saturation 94 in room air. He looks pale. Is a display of altered mental status, and he's maintaining his airway, his diminished bilateral breath sound, and he weak peripheral pulse, and he's continuous. He has head and torso with an obvious right femur deformity for this patient. After you insert line to IV for access, so the chest X-ray done for this one with reveals that pulmonary ossification on the bilateral contusion for this patient. After you give bolus for this patient, his heart rate is 150 beat, and his blood pressure improve little bit, 100/40. You send him for CT scan. There is small frontal contusion with this patient to rule out any intracranial bleeding. So CT scan for the neck and chest, abdomen, and pelvis is negative, but when he's returned from the CT scan, his blood pressure he's dropped to 68, from 100 to 68, and he's remain tachycardic with the heart rate is 150 beats. So now this patient present with motor vehicle accident with unstable blood pressure, and he's giving bolus, but still patient he's improved in the beginning and then the drop. Now we have to learn how to manage like this case scenario. Cardiothoracic trauma is common cause of the morbidity and mortality in children from age of first year to 14 years old. Is around 5 to 10% of the pediatric hospital admission from the trauma. Is injuries to be the chest account for around 25 of that trauma related to the mortality of that patient present to the Blunt trauma is most common than penetrating trauma. Blunt trauma is around 85, secondary to a motor vehicle accident or falls or non-accidental trauma, as will be discussed this one at the end of my talk. Pedestrian or bicycle sport and motor vehicle accident sport, violence or suicidal attempt. One of that's differential in the adolescent. School age can be found that's present with the pedestrian or bicycle sport. Penetrating trauma is around 15% and secondary to gunshot from 30 to 40%. That's mostly in the adolescent population. And when that additional organ system is involved, is increased that mortality with this patient. Thoracic trauma in children is more often associated with the multi-system. It's not isolated as thoracic trauma. You have to find other systems involved with that patient. You can see this is you can see in this paragraph of this one. We see this one how's what's the most common presentation of that thoracic trauma is pulmonary contusions. Around 71% of that presentation of that patient with the chest trauma. You can also find 35% of rib fracture or pneumothorax 25. Isolated rib fracture, just only 11% with that patient present with the chest trauma, thoracic trauma. Pneumothorax only 11%. This one, pneumothorax 6%, and cardiac around 6%. Aorta trauma is around just only 3%. What is different with anatomy in the physiology is, as you know, this incomplete ossification of that bony structure for that pediatric, and this make greater flexibility of the thoracic cage, more flexible ligamentous structure, and developed supporting musculature, narrow and short of trachea, more compressible trachea. That one is increased. That's picture is increase of that pneumomediastinum, diminished of that functional residual capacity with this patient, greater mobility of that mediastinal structure, and large cardiac reserve delay of that recognition of the shock for this pediatric age, and higher oxygen consumption of that per unit per unit body mass for this patient. Pre-hospital is very important and very playing an important part of management in that patient present to the ER. You have to not delay to transport the patient, should be avoid much possible. I have to be urgent shifting and transfer the patient from scene to the ER. And during that time with transferring, you have to keep patient board and give good oxygenation, ventilation, and treatment of that tension pneumothorax. If there is tension pneumothorax or patient, he's presented of picture of tension pneumothorax, and you have to go for needle decompression for this patient. Spinal motion restriction is very important, as mentioned in my first lecture. Immediate intravenous or intraosseous, if you feel difficulty to insert line, go IO. It is necessary for fluid and medication for this patient. You have to take good history for this patient. Maybe is only available from the AMS, and that's member that or parents brought that patient to the ER. History is very history very important. Very forceful mechanism is abrupt or acceleration or deceleration. For this one is very important to dig out more about this one to see this patient how's mechanism of that injury. Do you have to be sure he's motor vehicle accident or pedestrian accident? Or fall from significant height, non-accidental injury like history of maybe and reliable for this one or not matching with that presentation. You think about maybe his abused child. Maybe unreliable such as pulmonary contusion or blunt cardiac injury. So about physical examination for this one, sometimes difficult to rule out pulmonary contusion or cardiac injury. So is need some diagnostic study to help you if you use to rule out if this patient is with pulmonary contusion or cardiac injury. You can find this patient he's nasal flaring or some picture of respiratory distress, retraction, tachypneic, hypoxic. Contusion, that's lack of the breath sound and bony tenderness when you touch the chest wall. And there is crepitus sometimes if you find some subcutaneous emphysema, maybe indicate that underlying injury or fracture in the ribs. 70% of the children with the serious injury and had normal vital signs. Compromised airway is very important to rule out. Maybe there is bleeding or secretion or anatomical position of that flexed neck. So you have to reposition of the neck. And with, you just reposition and immobilize that cervical or neck if there is, think about there is trauma to the neck. Contusion or pneumothorax or pulmonary injury can increase that compromised airway or breathing. Circulation, sometimes circulatory collapse may be due to that hemorrhagic shock or vascular injury or tension pneumothorax or other tamponade physiological can happen for this one. There is a study done by Holmes, published on the few prospective study looking for the children with the thoracic injury. They found 6 clinical findings can help for chest injury. Abnormal chest auscultation, low systolic blood pressure, Glasgow scale is less than 15, or abnormal thoracic examination, or elevated respiratory rate, or femur fracture. He found that sensitivity of that patient, he's highly sensitive, that patient who's present with the abnormal thoracic examination and high respiratory rate is around 68 for abnormal thoracic examination, and high respiratory rate is around 51 for this patient. Who's more specificity high, that's patient with abnormal chest auscultation, and also patient present with hypotension. Also, that's high respiratory rate. Abnormal thoracic examination is around 64. So that will be guide you and help you for to rule out if there is any lung the thoracic trauma or thoracic injury. You have to go for a laboratory study. Hemoglobin and serum lactate, troponin is very important. Sinus ECG to rule out if there is any cardiac trauma. By looking for sinus tachycardia, rhythm abnormality, or ischemic change in the ECG. Chest X-ray is very important. This is not highly sensitive enough to identify some thoracic pathology, but it can be help to some cases. Abnormal just only 60 to 90 with the significant injury with this patient. Ultrasound is very important. Fast, no radiation, bedside can help for precardial fusion, pneumothorax or hemothorax or pulmonary contusion, and you can utilize in fast. I will discuss this one later on. Chest CT scan to find the injury in that maybe not be clinically or radiographically evident on the plain film. There is a radiation risk. Chest CT scan is much more sensitive for diagnostic modality than the chest X-ray and ultrasound for this one. But there is one study done by Holscher and retrospectively reviewed by trauma registry about 57 cases. He found that chest CT scan did not change that patient management, and chest X-ray were adequate to identify the patient needed urgent intervention for this patient. Renton conclude that a patient with the normal chest X-ray, chest CT scan rarely to be detected the clinical significant injury. Holchard and Barris, these identify that high risk mechanism like deceleration injury or crash torso injury or in abnormal chest X-ray, wide mediastinum, or potential that's all can be potential indicated for CT scan or chest scan as a part of that approach for this patient. Next, as I mentioned in the beginning, and I will not go through it. I explained thoroughly about that one in the first my lectures. Echocardiogram is very important. You can do that one during that you're doing the ultrasound, like bedside cardiac ultrasound for assessment. Allow the emergency clinician to rapidly assess if that precardial fusion or cardiac preload or ventricular size or global ventricular function, or that allow for that rapid treatment or decision for this patient and management for this patient. I will go some injury, specific injury related to the cardiothoracic injury. First, I will go to a patient present with the tracheobronchial injury. It's not common. It is very rare tracheobronchial injury in the pediatric age, and can happen in high or if this happen, it can be high mortality rate in that patient, and can happen from that penetrating trauma or blunt injury involving high speed shearing force, ranging from mild respiratory distress to respiratory arrest secondary to that tension pneumothorax for this patient. What you have to do, early bronchoscopy is indicated, and chest CT scan. Treatment from that, from observation and thoracostomy to operative repair for this patient. You can establish airway, can be complicated and should be done with the fiber optic assistant for that, like this scenario. Pulmonary contusion, as we mentioned in the beginning, it is very important and very common presentation in the thoracic trauma. Can happen with some cases with the laceration, most common time thoracic trauma in the children, and the patient present with the tachypneic as a chief and physiological response to the hypoxia. Pulmonary contusion leading to indicate this oxygenation and hypoventilation for this patient. Diagnosis can be just by X-ray. You can see some ossification or infiltration in the chest and the same side of the chest trauma. Maybe patient can go for CT scan for. You can see in this case, in the right side, there is a clear white infiltration or filtration for this one, or ossification for this one. It is clear this lung contusion. And you can see in that rim of that pneumothorax with this patient. Pulmonary contusion under surgeon treatment for this patient present like this scenario, you just would supplemental oxygen and close monitoring. You have to make fluid restriction, pain control, and early treatment of secondary pneumonia for this patient. Pulmonary restoration often is associated with the penetrating trauma or a rib fracture, like doing surgical or repair with the bleeding or leakage for this patient. Pulmonary hematoma is uncommon, but you can think about can be rarely progress to the lung abscess for some cases. Pneumothorax, one of that other important presentation can be presented. They are abnormal air collection in the pleural space, 1/3 of the thoracic trauma, associated with the pulmonary contusion, a small traumatic pneumothoraces that have that potential to expand, and more serious tension pneumothorax with this patient. So tension pneumothorax can be affect the cardiac output and cardiovascular collapse. And treatment just could supplemental oxygen, close monitoring. Small one need to be observed for 6 hours. Yeah, no need to go for chest tube for this patient. And repeat chest X-ray for this patient. Large pneumothorax need to be large bore and chest tube for this patient. small, stable, may need a chest tube if he going for mechanical ventilation or air transportation for this patient. Pneumothorax with the vascular compromise, severe respiratory distress, decrease breath sound in the with hyperresonance in the affected side. And contralateral, you can see that trachea is deviated and distended neck vein with the compromised vein, venous retain, and narrow pulse pressure with hypotension with this patient. Tension pneumothorax, you can see in this X-ray, this tension pneumothorax with this patient, you can see diagnostic and made that clinically, and we suspect treatment should be never to be delayed to obtain confirmation by chest X-ray. You can go by decompression. Bedside decompression can be performed using needle thoracostomy. Other important and challenging is that's open pneumothorax. That chest wall is injured, is created by direction flow of the air going in and out through the wound or penetrating wound, and that will lose of the negative intrathoracic pressure, leading to what an effective of paradoxical breathing. So it's make that breathing very difficult. Like this, we can see that penetrating wound. You can see that penetrating wound. This keep this bi-direction in and out, and that's loss of that intrathoracic negative pressure. That's make that difficult of breathing, and patient he is deciding. How to deal with this way? A patient with the open pneumothorax, a small injury can be treated by covering by the chest wall defect with the sterile petroleum dressing and placing of thoracotomy tube through the other fresh incision, not same شو اسمه wound,